I've known Juan for a few years now, and he's probably one of the kindest, gentlest, and most intelligent people I've come across. He's qualified as a hospital pharmacist. In 1992, he worked as an assistant professor of pharmacology in the Public University of Navarre and earned his doctorate in 1994. From 1994 to 2003, he joined the National Health Service, where he worked as a clinical pharmacist and then was appointed as the head of the Drug Information Unit in the National Health Service in Navarre, Spain. He's the former editor-in-chief of the Drug and Therapeutics Bulletin of Navarre and vice president of the province Clinical Trials Ethics Committee and the general secretary of the International Society of Drug Bulletins. His research activity is focused on pharmacoepidemiology and also on Cochrane systematic reviews. He is the director of the Navarre Cochrane Associate Center, editor of the Hypertension Satellite Group in Spain, and member of the Cochrane Knowledge Translation Advisory Group. At present, he is working on a RIAT project, restoring invisible and abandoned trials at the University of British Columbia, Vancouver, which is the subject of the webinar today. And without further ado, to a person I consider a friend and a mentor and just a bright mind in this area, I'll pass it over to Juan.
Thank you so much for this presentation, Aaron. Let me share my presentation with you. Okay, can you see the presentation?
I can't see your slides yet.
Let me see. Now?
There we go. Yeah, it's just loading. There we go. That's perfect.
Perfect. So today I wanted to share with you about a very interesting activity that is restoring invisible and abandoned trials. First, my declaration of interest. I'm employed by the National Health Service. Well, in fact, over the last almost 30 years. That means I'm a civil servant paid by the government. I have no funding from drug companies. And since September 1st last year, I moved to Vancouver and work at UBC on a RIAT project funded by the University of Maryland in Baltimore. So we're dealing with this very interesting initiative, RIAT. So first we'll describe a little bit what this RIAT is about. And we will also share about how to proceed. And for this, I'll take an example, which is the project I'm working on here in Vancouver. And that could be a good idea for you to have a better insight about this process. Okay? So in this slide, you can see what the current situation about trials is. For each trial, usually we have a lot of information, maybe tens of thousands of pages about a trial, but this is in the hands of regulators. And here it is depicted as all these papers under the blanket. And this information is not easily available to researchers. But instead, we usually rely on the publications in the medical journals that will draw people's attention, researchers, policymakers, practitioners, mass media. But first, we should bear in mind that summarizing all this huge information into just 10 to 12 pages, more or less, is quite difficult. And many important issues will be left out. And additionally, in these publications, there is reporting bias, conflicts of interest that may lead to disinformation. And sometimes the information in the medical journals does not really fit information in the trial. So for this, the so-called RIAT initiative was established in order to shed light on all this situation and see if we can make it easier to get access to the information under the blanket. And in case of discrepancies between the published information and the real information in the trial, we can restore this information and make it public, because we need reliable information, independent information for decision making. Okay, so RIAT is an international effort to tackle bias in the way research is reported in order to provide more accurate information. And this RIAT initiative offers a methodology to correct the record, and we usually make a difference between two possible situations. First, misreported trials. Sometimes there will be some trials where there is partial information or biased information, and then we can correct the trial and republish it in order to have a full picture of the effects of the trial. In some of the cases, what we have is a lack of information because maybe a trial was never published. So by publishing these unpublished trials, we can correct the invisibility of medical evidence. But there is very good news about it because there is a RIAT support center, which is based in the University of Maryland in Baltimore, that facilitates all the process. And these are really good, very nice guys who are very helpful. And the good news is that you don't really need to be highly knowledgeable in all this stuff, in all this process, because you may have a very sound and useful guidance for the RIAT process as such. And this support center will offer free of charge support, as I was telling you, and also competitions. That means competitive funding. In some cases, the RIAT project can be very easy, and you may not need extra resources for that. But in some of the cases, well, maybe it is a time-consuming process or complicated, I don't know. And for that, you can apply for competitive funding, and if you're lucky, you can get funds for that. Okay, let me tell you about the first trial restored. This is a very interesting case, the so-called study 329. This is the published study, efficacy of paroxetine in the treatment of adolescent major depression. And according to the authors, the conclusion was that the paroxetine is generally well tolerated and effective for major depression in adolescents. But the point is that some researchers understood that there was some discrepancies between the information published in the medical journal and the information they could have access to. And they decided to go for a RIAT project and restore the information. And the conclusion was that neither paroxetine nor high-dose imipramine, which was the other drug tested in the trial, showed efficacy for major depression in adolescents. And which is more worrisome is that there was an increase in harms, including an increased suicidal ideation and behavior with paroxetine versus placebo. So if we look at the original publication, we could conclude that this drug is safe and effective in adolescents. But if we go to real data, we could conclude that we should never, ever use this drug in this population. So this is shocking, and the difference is really huge. And this is a very good example to showcase the importance of rioting, so to speak. And here you can see the final publication of the study 329 after restoration that was published in the British Medical Journal. This RIAT initiative is rather new. So far, there is a short list of completed registrations. So this is something really worth promoting and working on. In the 2020 competition, there were 3 projects that were awarded funding, and one of them was the project we're going to talk about, the one I'm coordinating here in Vancouver. I kindly suggest you that you could visit the website at restoringtrials.org and learn more about the RIAT initiative and how to present, apply for funding and all this stuff. And now let's take the example I'm working on, and let me conduct you in a natural and logical approach. First, I will be giving you a briefing about the FOURIER trial. Second, we can discuss about why the FOURIER trial. There are many trials all over the world. Why this one and not another one? 3, we can take a look at the publication and see what we can pick up out of reading the New England publication. I can tell you in advance that we may find scarce and inconsistent data and relevant conflicts of interest. After this, we can apply for regulatory documents and see if we can have any further information about this trial. Next, we can take a look at the clinical study report, which is one of these additional documents that we can look into it. And this one will be highly valuable to grab a better insight in the trial. And if appropriate, then we could proceed and apply for the RIAT project, and we'll see what you may need to apply for that. And then I may share with you a little bit about methods and preliminary results of our project. And also we may discuss about the importance of a RIAT initiative. Okay, so keeping this in mind, let's go ahead. First, the description of the trial. So before the FOURIER trial, we already knew that this drug was really good at lowering cholesterol levels. In fact, you can get your cholesterol reduced in between 50–66% compared to baseline, which is a huge drop. And this is why this drug was approved in 2015 by most regulators all over the world. But we should also bear in mind that this is a surrogate outcome, and we should have more evidence about the clinical benefits of the use of this drug. Because at that point, we had no idea about the effects of this drug in reducing total cardiovascular events, total serious adverse events, cardiovascular mortality, total mortality, and so on. And this is why the FOURIER trial was designed, in order to give an answer to all these questions. This is a double-blind placebo-controlled trial. The population, the target population, were people aged between 40 and 85 years with a clinically evident cardiovascular disease. So it was secondary prevention patients. Their LDL cholesterol levels should be above 70 milligrams deciliter, which is 1.8 millimoles per liter, in spite of treatment with statin and with or without ezetimibe, okay? And then evolocumab could be administered in two different ways, every 2 weeks or once per month, always subcutaneously. The primary outcome in the trial was a composite of cardiovascular mortality, myocardial infarction, stroke, hospitalization for unstable angina, or coronary revascularization. There was a key secondary endpoint, which was cardiovascular mortality, myocardial infarction, or stroke. Okay? This was a really large trial, over 27,000 patients, which is a huge number of patients. And the duration of the trial was scheduled for 58 months. However, it was early terminated halfway through, just about 26 months after getting started. And the conclusions of the authors were that evolocumab is a really good drug in reducing cholesterol levels and also reduce the risk of cardiovascular events. And they also state that these findings show that patients with atherosclerotic cardiovascular disease benefit from lowering LDL cholesterol levels below current targets, right? Okay, let's move ahead. Why did we choose this trial? Well, this trial is really important because of some reasons. First, this is a new mechanism of action, and we know nothing about these drugs, and it is worth looking into the trials for new mechanism of action drugs. Also, this is the first in class. So it is especially important to pay attention to the first drug in a new class. As I was telling you before, this trial is really large, and this could set the evidence about these kind of drugs. Because you know that whenever you undertake meta-analysis, large trials will weight a lot. And in this case, it is really hard to believe that we may have many more trials this big, this large. And probably whenever this FOURIER trial is included in a meta-analysis with some of the trials, the conclusions and the results of this trial will determine the evidence, right? And also, if we believe in the cholesterol theory, after such a big drop in cholesterol, we should expect some relevant clinical outcomes and clear benefits in mortality or morbidity out of using this drug. Okay, so in what can we see out of reading the publication in the New England Journal of Medicine? Well, first, in the protocol section, there's a supplementary information, and you can read that this trial was amended several times. Amendment 2 was approved soon after the trial had already been started. And one of the many things that reads is that all-cause mortality in some cardiovascular outcomes like myocardial infarction, stroke, revascularization, hospitalization for unstable angina, hospitalization for heart failure, transient ischemic attack, will not be considered as serious adverse events in this study, but handled as efficacy endpoints. Well, and what does this mean? Well, the consequence is that cardiovascular events are split into efficacy and safety outcomes. And in practice, no information about the former will be given in the narratives in the clinical study report. We'll see that later. And no information about the latter will be published. So this leads to partial, patchy information about cardiovascular adverse events. Also, the amendment reads that Amgen will review all fatal endpoints. And there was a change in the secondary endpoint. At first, it was time to hospitalization for heart failure, but to this initial endpoint, another individual endpoint was added. So it was the former plus cardiovascular death. So the consequence is that heart failure events alone will no longer be published, which is really sad because we're missing information out of this amendment. And finally, another secondary endpoint was added, which was time to ischemic fatal and non-fatal stroke or transient ischemic attack, whichever occurs first. So first, let me draw your attention about all this outcome switching after the trial having started. This is not very much reassuring about the quality of the trial, and this casts doubts on the way the trial is managed. Okay, if we go a little further, we can see that there are some rare things in the trial, like all patients were taken electrocardiogram at baseline, but it was only 15% of patients who were undertaken taken electrocardiograms at that point in the trial. It was scheduled for week 12 and 24, but it was just 15% of patients. So that means we may have some under-registration of events, including silent myocardial infarctions. Well, regarding the results in the trial, we could confirm that the drug is highly effective in lowering cholesterol. There was a big drop from 90 to 30 on average milligrams per deciliter, which is from 2.3 to 0.77 millimoles per liter. And this drop remained steady throughout the follow-up. So it is clear that the efficacy of this drug in lowering cholesterol is really good. If you take a look at the results, the clinical results in the trial, then you may not feel it so good, because in the primary endpoint, there was statistically significant differences between groups, but the results in terms of absolute risk reduction were not that impressive, only 1.5%, meaning that we should treat some 63 patients for 2 years, just for one of them to get benefit out of treating these 63 patients. But more surprisingly, we can read that cardiovascular death was increased, numerically increased, and also overall mortality was increased in the evolocumab group. So this is not very much consistent with a drug that reputedly benefits cardiovascular events, meaning that it may reduce heart attacks and other cardiovascular events. This is not very much consistent with the fact that not only cardiovascular death is not decreased, but it is slightly increased. So if you take a look at the graphs in the publication, you can visualize in a much better way about the so-called modest effects of the drug. If you take a look at the graph from 0 to 100%, as should be done, you can see that the curves overlap, and it is at the very end of the follow-up that there's a slight difference between treatment groups when there's very few patients followed up. And this happens both for the primary outcome and for the key secondary outcome. Well, and we can also ask ourselves about this primary outcome. This is a composite of different individual outcomes, but we can see that cardiovascular mortality is increased, myocardial infarction, stroke, and coronary revascularization decreased, and hospitalization for unstable angina remains more or less the same. So we should ask ourselves, whenever we address a composite outcome, we should ask ourselves at least 3 questions. First, is the incidence of events reduced in all outcomes? Well, no, it is not. If reduced, was it in a similar proportion? Obviously, it was not. And are the results in individual outcomes consistent? No, they're not. So we should cast doubts on the real effects of the drug out of analyzing the effects or the results in the composite outcome. Another relevant issue that we can spot from the publication is that most cardiovascular deaths were classified as other cardiovascular causes, as many as 75%. Well, usually people die of heart attacks, or strokes, or fatal heart failure, but it is very rare that the vast majority of cases were other causes of mortality. Additionally, we have no information about heart failure in the publication, no information about fatal nor non-fatal cases, no information about heart failure as an outcome alone by itself. If we ask to ourselves, were all cardiovascular events published? No, they were not. As I was telling you before, they were split up into different groups. Those tagged as efficacy outcomes, in the publication, we can see the numbers, but in the clinical story report, these cases are not described. We cannot read about them. But for cardiovascular events tagged as safety outcomes, well, there's no mention about this in the publication. And in the clinical story report, all cases are described, but this information was never published. And how about total serious adverse events? They were never published. And how about blinding in the trial? Well, it is said to be double-blinded, but you know that whenever a drug reduces cholesterol to a great extent, if you're aware of your cholesterol levels as a patient or as a doctor, you can have access to cholesterol lab test results of your patients, then you can easily say, you can guess what the treatment group your patient is in. So it isn't clear whether blinding was guaranteed. Well, let's take a look at the information flowchart in the trial, which is very interesting. In the trial, there was an executive committee advisory to the company, to the manufacturer. And this committee, its main objective was to advise the company on the trial design, implementation, analysis, at the end of the trial, communication of results, and also this committee would set the termination date of the trial. The co-chair of this committee was Dr. Sabatin, who received almost $160,000 from the company during the time this trial was designed and implemented. There was a lipid monitoring committee that handled unblinded information and was advisory to both the executive committee and the company. The chair had already received some money from the company too. There was another data monitoring committee whose objective was to communicate major safety concerns and recommendations regarding study modification or termination. This committee had access to individual treatment assignments. And the chair of this committee received almost $160,000 from the company. Of note, the company had access to the clinical report forms. We'll discuss about this later on, but this is the primary information. Whenever there is an event or the doctor writes anything about any patient in the trial, that will be in the case report form. So this is the fundamental primary information in the trial. And the doctors could propose some patients as potential cases for potential endpoints. The company could do the same. And in the end, it was the clinical events committee in the trial that would decide on whether that case was a final endpoint, it was an endpoint or not, or the diagnosis had to be changed, or whatever. This clinical events committee is part of the TIMI study group, whose chairman was Dr. Sabatin. But Dr. Sabatin, thereby, is the main author of the publication, chairman of the TIMI group, co-chair of the executive committee, and deputy editor of the JAMA Cardiology. And out of all the money he received during the trial, almost $140,000 was directly linked to the promotion of evolocumab, the drug in the trial. And he also received, as associated research funds, over $11.5 million. And in spite of this, he declared having no conflicts of interest at the time of the study publication. That was in 2017. Some 2 years later, we published our intention to restore this trial in the British Medical Journal, and this also included restoring the conflicts of interest declaration. And a couple of months after this, Dr. Sabatin changed his declaration and acknowledged he did have conflicts of interest. Okay, after all this, we decided to apply for regulatory documents. And let me give you a briefing about what kind of information we may have out of regulators. This is the so-called common technical documents. If you look at the bottom of the pyramid, you can see the primary information that deals with quality of the drug here on the left. In the middle, you can read non-clinical study reports. This is primary information on the effects of the drug in animals and other studies. And then on the right, you can read clinical study reports, module 5. This is a very important information for us as researchers. And there's a vast information about the trial. In the upper layer, you can read about many different summaries. This is all about pool information, pool analysis, overviews of the information below. And on top of the pyramid will be information about regional administrative information that may not be so important for us. So we'll focus on this part on the bottom right of the pyramid, the clinical study reports. And as part of the clinical study report, we could have access to the case report forms, but it is not that easily available. Now we'll tell about it. And another very important source of information is the inspection reports, but this is very difficult to get access to. So what is the clinical study report? As I was telling you before, the publication may take around 10 to 12 pages. In this case, it was 9 pages. The protocol of the trial, almost 600 pages, but the whole information we have about the trial, in this case, is about 50,000 pages, more or less. This is the clinical study report, and this is in the hands of regulators. At present, we can apply for this information. And here you can see the website of the European Medicines Agency. The FDA can provide this information under the Freedom of Information Act. Health Canada can do the same. Now, Health Canada has started to publish clinical study reports on a regular basis. And you can apply for that. It takes time, and it is important that we get used to applying for clinical study reports so that this activity becomes more normal. As part of the clinical study report, you can read at the bottom of this slide, case report forms available on request. As I was telling you before, the case report forms is the primary information in the trial. This is an example of a blank case report form of the FOURIER trial. And take, for example, you're dealing with a patient, you're a doctor, and there was an event, and then you have to keep record of what happened to that patient. Then you go to the case report form, and in this case, you can read a history of congestive heart failure. Yes, no. If yes, you can take, it was class 1, 2, 3, 4, and many other clinical details, which is really helpful and which is a really wide and useful information. All this information is technically part of the clinical study report, and we should have access to. So in short, this document will collect all data from each patient, including efficacy and safety events, right? So what we decided is to apply for this information, and we approached the FDA, but we were said that probably they have this information because they require by default all this data from the company, but they were very busy, and it would take them some 3 years to address our application, and also another 2-3 years to send the information. So I was kindly invited to cancel the application, which I did not. But the fact is that we don't have the case report forms. We also applied EMA and Health Canada for the case report forms, but in both cases, they said that they hadn't requested this information from the company at the moment of the submission of the documents for the evaluation of the new indication. And legally, they had no right to require all this information from the company because they hadn't done it in due time, which is, well, probably it is legal, but it doesn't make any sense that the regulators cannot ask for this information. Well, at least Health Canada promised us to release the clinical study report within 120 days, which they fulfilled. And we could get access to the whole clinical study report. So another source of information is the inspection reports. In all trials, regulators will undertake some inspections in order to see that everything is fine, there is no issue regarding quality of the implementation of the trial. And this is a landmark paper by Charles Seife, published in JAMA. And what he did was to require inspection reports from FDA under the Freedom of Information Act. And he realized that in some trials, very important trials like Aristotle, that was the pivotal trial for PIC7, there were important issues regarding falsification, data falsification, Y stands for yes, adverse events, misreporting, protocol violations, etc. So all this information should be publicly available, but we have no access, and it is very, very difficult to get access to it. But we should bear this in mind and claim for this information to be available. Okay, then we take a look at the clinical study report. As I was telling you before, there's a lot of information. And what can we see at first sight? Well, first we could spot that if we take a look at patients with at least one cardiac event, this information was never published in the publication, there was no differences between groups. So, and it was almost 4,000 unpublished cardiac events tagged as safety outcomes, and there was no difference. So it is not really consistent that in the main outcome, there are differences between cardiovascular events tagged as efficacy outcomes when those tagged as safety outcomes, well, in those cases, we find no differences. Another matter of concern is that when you compare the publication versus the clinical study report, there was some mismatching in fatal myocardial infarction and stroke cases. If you take a look at the results across regions, you can see that, well, most of the patients came from Europe, over 8,600 patients. And in Europe, there was no statistically significant difference between groups in the primary outcome. That was the case of Latin America too. In the statistical significance was obtained thanks to the contribution of patients from North America and Asia. And there is no grounds, there is no rationale for what possible genetic issues or racial aspects that could justify these differences. And more importantly, when you go and take a look at the narratives, you can find very strange things. The narratives is the summary of the clinical record of each patient. And if we read the death outcome narratives, we can see in all cases, this first line on top of the page reflects the diagnosis of the doctor in charge of the patient. In this case, he wrote death, just death. In the box, you can see the adjudication, meaning what type of death was that. There are three options: cardiovascular, non-cardiovascular, and undetermined. And in the box on the right, you can see the adjudicated cause of death, which is the cause of death established by the Clinical Events Committee in the FOURIER trial. And in this case, you can see that in the narratives, you read that the patient suffered from a myocardial infarction and died, but it was labeled or tagged as a sudden cardiac death, which is not correct. And we thought, well, maybe this is one only case, don't know, but we could spot so many cases where patients like this is another case of myocardial infarction disguised as sudden cardiac death. This is another myocardial infarction disguised as a non-cardiovascular death. Road traffic accident that was adjudicated as a sudden cardiac death, which is not correct. Another myocardial infarction adjudicated as sudden cardiac death, and many more cases. So we thought that it was really worth looking into the clinical study report and applying for the RITA project. So in order to apply for a project, you need at least three important things. First, call to action. That means you must publish in the British Medical Journal that you want to restore the trial and make it public. Second, you should contact authors and let them know about what you're going to do and invite them to restore by themselves the results of the trial. And if they don't, or they don't respond to your emails, then you have the right to proceed and go for the restoration. And third, you must provide that you have enough evidence to go ahead and restore the trial. This is the restoration of the FOURIER trial, the call to action published in the British Medical Journal. And let me tell you about the preliminary results. First, we wanted to restore total people with at least one serious adverse event, which was unpublished, the overall cardiovascular mortality, the cardiovascular death due to myocardial infarction, stroke, or heart failure, the latter was unpublished, and total cardiovascular serious adverse events and other events. Both were unpublished. Okay, for this, we reviewed all the narratives of all death outcomes and serious adverse events, select cases for discussion, set up two committees, one to re-adjudicate the cause of death whenever necessary, and a validation committee that would supervise the decisions of the re-adjudication committee and make sure the quality of the process was perfect. And also, after that, we carried out the reanalysis. Our idea is to draft three papers, three articles, one on the restoration of mortality data, another one on serious adverse events, and the third one on ethical and technical issues derived from this experience. Well, let me tell you that we found a lot of inconsistencies between the type of death in the adjudicated cause of death. Some 26% of total deaths were inconsistent. Take, for example, in here, you can read a cardiovascular death, but the adjudicated cause of death had nothing to do with the cardiovascular issues in a number of cases. In green, you can read deaths classified as non-cardiovascular death, but in the end, the clinical events committee decided to tag them as cardiovascular or undetermined deaths. And of note, there was a huge amount of undetermined deaths that were switched into sudden cardiac deaths, 91 of them. And how about the results after re-adjudication? In the New England publication, you can read that in the evolocumab group, there was 25 myocardial infarctions and 31 strokes, and all the rest was other causes of cardiovascular death. If you take a look at the narratives, you can see that in this group, we found 11 more cases of fatal myocardial infarction, 8 less cases of stroke. We found 43 sudden cardiac deaths that were never reported, 31 fatal heart failure cases never reported. So there's a big difference in the numbers. And in the placebo group, we found more or less the same. I'm going to rush just to make it shorter. One of the things we've done is just to make a report of all cases where there was a re-adjudication, or just to be more transparent and for anyone to double check the information. Take, for example, case number 13. You can read on page 23778 in the clinical report that this patient was treated with evolocumab. The doctor said it was a myocardial infarction death, but the clinical events committee changed the diagnosis for sudden cardiac death. But in the narratives in this page, you can read the subject experienced acute myocardial infarction and died on the same day. So that is why we cross out sudden cardiac and wrote myocardial infarction. So everything is transparent and everything can be double checked. This is very interesting. And whenever I read a clinical trial on cardiovascular disease, I can read overall mortality, cardiovascular mortality, and I take it for granted that the difference will be non-cardiovascular mortality. But after this experience, this RIAT project, I've just realized that there's a number of cases that we don't really know what the cause of death is. And we found that at least 1/3 of the patients died of undetermined causes. And this is very important. And this let us know about the need for carrying out autopsies in clinical trials to have a better insight about the cause of death, because in many cases we don't really know. And when we adjudicated the results, the narratives, we could spot there was a huge imbalance in cardiac death between groups. We observed 113 cases in the evolocumab group versus 88 cases in the placebo group. However, if you take a look at the vascular death, there is no difference, 37 cases in each group. So we can't rule out that this drug may have some deleterious effects on heart, and this is something to be followed up. Well, more details about results in forthcoming publications. And just to finish, let me share a couple of slides with you about the importance of RIAT initiative. As you may have picked up after this presentation, it is really important to have access to regulatory documents and individual patient data if we want to assess drugs in an appropriate manner. And though some progress has been achieved, researchers should be provided with all available evidence at short notice. I find there is no ethical or technical reason to hide clinical information. This RIAT initiative helps obtain a much better insight on the clinical trial information. The good news is that the RIAT initiative offers technical support and competitive grants to make it easier to go through. And my view is that we need more researchers working on RIAT projects to have a real picture on the effects of drugs, and also showcase the need for regulators to release all available evidence. And we also have an important challenge, that is how to incorporate RIAT results to reviews, to clinical practice guidelines, in general, to decision-making processes. And this is all. Maybe I went too fast, and I want to thank everybody around this project. Special thanks to all my colleagues at UBC. I'm really proud of being part of Therapeutics Initiative. A big thanks to all my team in Spain, and they are great, very nice guys. And very special thanks to all RIAT Support Center members in the University of Maryland, especially Peter Doshi and Anisha Urwani. So thank you all, and I'll be happy to take any questions or comments.
Great, thank you, Juan. That was a fantastic presentation. Very, very interesting. We'd love to have you back to hear more of the details. So maybe we can work on that. Because in the interest of time, I know some of the people that have questions, and so I'll connect you directly with them.
Sure.
Because we won't be able to get to all of them, but I'll just get through some of the others. So one question is, how do you motivate those who conduct trials to provide autopsies which are more unambiguous than the narratives in the reports?
Well, that is a good point, but I think this should be regulated by law. because clinical trials are very costly, very time-consuming, and I think it is worth. I mean, there's no much added effort in making autopsies, and if regulators express the obligation of undertaking autopsies, we could have a better insight about the cause of mortality in the trials, and I think that this should be done.
Not to make it optional, that makes sense. Okay, and one final question, Juan. There are many comments about how wonderful the presentation was and thanking you for your effort. One question here: from previous presentations I've seen with lead authors that they have noted that protocol amendments are sometimes clerical entry corrections. So someone registers the details of their protocol. It wasn't necessarily a change that occurred. It was just the way it was entered initially was wrong, so they're correcting it. Do you have evidence from FOURIER that the changes in outcomes were actually changes in the outcomes, or could it have been correcting clerical errors?
Well, to tell you the truth, I have no evidence about it, but these amendments were authorized or approved after the trial has started. So my guess is that it was not a matter of typos or these kind of issues. I think it was a real issue in the trial, and this is worrisome.
Okay, a couple of comments. One is you had mentioned that the company or the sponsor had access to the case report forms, and someone commented that the sponsor of a trial must submit SUSARs to the regulator, and so they would need to have access to the case report forms, and that could be a reason why. And also another comment suggesting that autopsies are very expensive, as you had alluded to. There's about $3,000 each, so that that may be part of the reason regulators or researchers aren't really motivated to make it mandatory. Not that they shouldn't because of that, but
I agree that these autopsies are costly, but in the context of a clinical trial, it is just peanuts. Because
yes.
If you take if you look at the whole thing and you take into consideration that there are not so many deaths. In this case, there was 870 deaths because it was a research trial over 27,000 patients. But in general terms, in trials, we don't have so many deaths. And so money is not an issue at all. And the previous comment was, I can't remember.
That sponsors have access to case report forms because the SUSAR regulation.
Oh yeah, they should have access too, but maybe once the trial is finished. But because during the trial they have the chance of intervening in the trial to a great extent, and then we couldn't call this a really independent trial if you give the chance of the manufacturer intervening at a very early stage in all processes, in all documents in the trial.
Very good point. Well, with that in mind, again, Juan, thank you so much. An amazing presentation. It's always a pleasure to hear you speak. To the audience, thank you for calling in and submitting questions and comments. We really appreciate your time. And hopefully all of you will stay connected to the Therapeutics Initiative. Have a lovely rest of the day or rest of the evening, wherever you are. Take care, everyone.
Thank you so much.